Hello class, this is Professor Turpin. I'm going to try to use three clips of some different information, one on pre-op care, one on intra-op care, and one on post-op care. And so I'm going to probably speak pretty quickly, but I'm trying to do these so that you have these as reference for later on. A good bit of our test is compiled of surgical questions, so I want you to have some study materials. The preoperative period is really kind of defined as when the patient is, before the patient is scheduled for surgery, but at the time, but that period ends when they are actually transferred to the OR suite. Pre-op care can occur in an ambulatory care center. It can occur, in an inpatient room prior to going to surgery. So this preoperative period can be in different locations. Nurses, to do the preoperative care, they serve as an educator. Sometimes they're an advocate, working out details for the patient and or family. And often one of their main responsibilities is really to promote health and safety and ensure that all the regulatory things are met before someone can go to surgery. These are just some of the reasons for surgery. Obviously somebody might be having surgery just to diagnose a problem. They may also actually be having, say, like an appendectomy to remove appendix, then that's curative for them. It might be restorative, like a joint replacement surgery. Or it could be a palliative surgery where someone has a tumor that can't totally be removed, but enough of it can be removed so that pain is relieved, for example. Or patients can have cosmetic surgery. So these are just a few of the reasons. You also see that surgeries are often classified based on some different categories. One is urgency. An elective surgery is one that's done, just when you elect to have it done and when your physician can fit you in. It's not anything that has to be done right away. Urgent is something that needs to be done fairly soon. And emergent is life-threatening situation that requires surgery. They also classify surgery with the degree of risk. Is it minor surgery or major surgery, depending on how much organs and tissues are involved in the surgery. And then sometimes you hear it classified into simple surgery, radical surgery, or minimally invasive surgery. A key thing that has to be a major nursing intervention in the pre-op period is to try to relieve anxiety. Most people are very stressed out, very worried about surgery, sometimes very emotionally upset, and so they require a lot of re-emphasis on their pre-operative teaching. They may have had teaching in the physician's office 2 or 3 weeks ago in preparing for surgery, and now because of anxiety they're having difficulty remembering some of those specifics. You also want to encourage communication from the patient so that you're better aware of what they're really experiencing, so you can help solve any issues they have. Sometimes you want it to be just dim and promote rest. Some pre-op holding areas may have like some music or TV that someone can watch to distract them, or headphones to wear. And then you also spend some time teaching family members as well. This is an important factor of skin preparation prior to surgery, and a lot of times this is done in the holding area. Breaks in the skin really increase the risk for infections. So patients may be asked to really shower and cleanse the operative area or their whole body with antiseptic solution. Sometimes this might be chlorhexidine. And then it used to be that people would shave the hair in the area where surgery was going to be done, and they found that shaving will generally cause a higher risk for infection because of the skin becoming irritated from that. So we never shave hair anymore. Hair can be removed by using electric clippers or using depilatory creams only. You may see preoperative medications being given. Sometimes it's something for anxiety or a sedative, just kind of getting them prepared and ready to go into surgery. Sometimes there's other meds that are given that are like really to prevent serious problems or reduce the risk of things such as bradycardia. Often they are put on a H2 histamine blocker that cuts down on gastric secretions. And this is because you don't want patients to have reflux, because it is found to kind of increase the risk of pneumonia. And then, as we talked in our pain lecture, sometimes patients are given pain medications before they actually go back into the OR. The assessment of these patients is very important, because they may have just been assessed a few weeks ago in the doctor's office, so something could have changed. These are some of the key categories that are really important to know about. How well they've tolerated anesthesia in the past. Have they made blood donations to prepare to have some donations for surgery? And talk a little bit about how they're going to manage some of the things when they go home, just to get a overall understanding. And then, of course, as we know, drugs and substance abuse may have a bearing on how well they manage their pain and or their actual anesthesia. These are some key physical assessment things. Of course, we want baseline vital signs. We want to really focus on the area of the problem, the reason they're there, and all the body systems that might be affected during a surgical procedure. And then any abnormal findings have to be reported to the surgeon and the anesthesiology personnel prior to the patient ever leaving the holding area. And in terms of system assessment, I won't read these to you, but obviously we want to know if there's some severe cardiac history. We want to know if there's some severe respiratory history, because those, as well as renal and urinary, because all of those can have a major impact on how you tolerate anesthesia, or whether drugs build up in your system and can't be excreted out of your kidneys. So all those can have a big bearing, and we have to have a very good understanding of the risks there. Also, for neurologic, you want to know information about the current level of consciousness, because when they're in the PACU and in the postoperative phase, you want to make sure that they're returning back to their baseline. So knowing what that baseline is very important. And also, depending on what kind of surgery they're having, it may affect musculoskeletal or nutritional status, so we want to know what their status is before. Obviously, malnutrition and obesity really increase surgical risk, so being aware of those risk factors is important, and psychosocial concerns that the patient might have. These are just a list of a lot of diagnostic tests that are usually ordered in advance of surgery, and you want to have all these results on the record so that the physician can review this and be aware of these. If any abnormalities are found in any of these, they need to again be communicated very readily. For chest x-ray and ECG, those are primarily because you want to baseline, see what the lungs look like and what the heart rhythm looks like before surgery, in case there are any changes with that postoperatively. Informed consent, usually the surgeon obtains this assigned consent before sedation and or surgery begins. The nurse usually will clarify facts and dispel any myths about the surgery that a patient may have heard, but make real clear that the nurse is not responsible for providing the detailed information about the procedure. If you have a patient that is asking a lot of questions about things that the physician should have explained in detail, doesn't mean that the surgeon didn't explain it, but maybe at this point in time the patient has forgotten, and really before you go forth with a surgery, you generally are going to make it a priority to call the physician, stop the case until that information has been reshared and re-understood and verified. Patients are allowed to make an X for their signature on a consent if they cannot write, whether it's physical or they never learned how to write. And then usually people will put in parentheses patient's mark out beside that on the consent form. It is acceptable in an emergency to get telephone authorization, and just know that there is a specific next of kin list provided, or by the healthcare power of attorney. Those are the people that have to be responsible to sign when the patient is deemed not competent to sign for themselves. Of course, many of you have been in clinical already, have seen some patients that were NPO after midnight, nothing by mouth for 6 to 8 hours before surgery. This is to make sure that there's not risk of risk of aspiration, where they may get pneumonia from that or have some severe problems with that, with their breathing status after surgery. The other thing is you have to really stress adherence to this. Most nurses will go ahead and remove the water pitcher and any kind of drinks or anything from the room. If you should find out that they've had something to drink all night long, the surgeon should be notified, and sometimes surgery may have to be canceled if those instructions are not followed. In some cases, the physicians will allow more critical medications, like for cardiac disease, respiratory disease, seizures, or maybe high blood pressure, to go ahead and be given with just a small sip of water, in an effort not to interrupt that routine. When in doubt, page the physician or anesthesia and make sure what their wishes are. Also, in some cases of surgeries, an intestinal preparation is given. This is to kind of cleanse out the colon. It may reduce the number of bacteria in the intestine. Like most times, patients are given some type of a oral laxative, and then followed up with an enema to make sure that what's coming out is clear. Patients are going to be at risk for a venous thromboembolism, and these are all the risk factors. So make sure that you memorize these. You should be really aware of how each one of these has the potential to cause someone to have a VTE, because you want to know that that is something you've got to watch really heavily with patients that fit into these risk factors. These are some of the things that are done. Obviously, some of you have seen compression hose that have been put on patients. They should leave these on all the time after surgery. If they should have surgery in one leg and not the other, then they still need to wear it on the one that was not operated on. And in lots of cases, the patients will also be put on prophylaxis, low-dose Lovenox or sub-Q heparin dosages that are given usually starting about 6 hours after surgery, as long as there's no active bleeding. But again, this will be based on physician order. You also want to do a preoperative chart review and really ensure that all documentation, everything about the procedures, the orders are all complete. If there is a consent form, make sure it's complete. It has all the, what side the surgery is on. Make sure all that's clear. Make sure that you let the patient know that the area of their body will be marked before the surgery begins, and that is a huge, big safety area for making sure we do right side surgery. Any allergies need to be documented. Height and weight, the most recent one needs to be done because meds are calculated based on that. And then make sure all the tests and everything are available. If there is a key lab result that was never ordered, it's that time to call the doctor and see if that's needed before the case starts. This is some more things to prep the patient. Make sure they remove most of their clothing, provide them with a hospital gown, have their valuables provided to the family, or have them locked up if there's not family there. If rings can't be removed, they need to be taped around them. Make sure the ID band is on and it's legible. And these are the list of all the items that are, artificial items that patients may have that need to all be removed before you send them down. Just know that these are some of the risk factors that make older patients much higher risk. And we've talked about some of this with elderly patients already. These are some other issues that are considerations. And that's the end of our pre-op lesson.